I'm very glad today, and I'm very honored to present our guest, Dr. Lydia Kupriyanova.
Hello, hello. Thank you very much. I think I introduced myself. Don't worry.
The mic is yours, doctor.
Yeah, thank you. I can start, yeah? Okay, hello, dear friends. I'm really happy being here today evening. And my name is Lydia. I'm a veterinary dermatologist and endocrinologist. I live and work in Moscow, Russian Federation. And I'm a dermatologist more than 10 years. And today I'm going to discuss rational use of glucocorticosteroids. Honestly speaking, in Russia, steroids are one of the most controversial group of drugs in veterinary practice. Maybe you have the same problem in your country. On the other hand, there is a myth that steroids can cure any disease. We have in Russia absolutely awful phrase. No one will die without prednisolone. Yeah, if any drug doesn't work, use prednisolone. Maybe you will be lucky. Yeah. And on the other hand, some doctors are strictly against steroids. They say you can kill your patient, don't use them. And as you understand, both statements are questionable. We have a lot of disease, for example, pemphigus foliaceus, for example. There we can't treat our patient without steroids. But we have a lot of cases when we don't use steroids, and today we will try to figure out whether the drugs are really the dangerous or they are okay, and what complications their use can lead to. So let's go. By the way, I forget, excuse me, you can write and text questions in the chat and I will answer them at the end of the lecture. So now let's start. Okay, what about steroids working? They have a lot of effects to the immune system and to the organism because any pets have own steroids. Yeah, we know about endogenous steroids. And what about drugs? They block the synthesis of inflammatory mediators, suppress T lymphocyte proliferation, block B lymphocyte migration, inhibit the release of cytokines from lymphocytes and macrophages, and reduce antibody production. We have a lot of effects, yeah, for each groups of immune system. So we have a lot of side effects, of course, yeah. The most of them are polyuria, polydipsia, of course, polyphagia, different behavior changes, suppression of endogenous glucocorticoid synthesis, yeah, and we know about this condition like iatrogenic Addison's syndrome. Gastrointestinal bleeding, steroid hepatopathy, diabetes mellitus, of course. In cats, more frequently, we can check this condition. Immunosuppression, decreased protein synthesis, impaired wound healing, and increased proteinuria, of course. The risk of complications is higher with long-term use and high doses. Okay, what about types of steroids? What types of drugs do we have? We have three main classification, and the second one is by duration of action. Okay, we have short-acting steroids, and we prefer them because we have smaller side effects. In Russia, we have prednisolone. I know that in Europe, doctors can use prednisone as the same, and methylprednisolone. We have intermediate acting steroids, for example, triamcinolone. In some cases, in cats, triamcinolone can be drug of second choice to treat itch or pemphigus folations. And long-acting steroids, dexamethasone, and I don't like use this drug in cats and in dogs because there is a lot of side effects, diabetes mellitus, for example, and I prefer short-acting drugs. If we comparative activity of glucocorticosteroids, we understand that it's different. For example, we know that hydrocortisone have this activity like 1, yeah. Prednisolone like 4, but dexamethasone, look, 25. It's more than 5 times activity than prednisolone. Of course, he will be more effective, but there are extremely more side effects. And we can use steroids systemic in tablets or in injections, and topical like sprays, gels, shampoos, and etc. And if we can use topical steroid, it's better than use systemic. But in some cases, it's impossible. It's impossible. Use topical steroids. Okay, and we know a lot of diseases when we use steroids, but let's discuss when should systemic steroids be avoided. There are a lot of cases in my practice too. Let's discuss it. Okay, I think every vet know that if we can pruritus, like the main syndrome, we use steroids. Of course, we know how they work, and we know that steroids can work to itch. But itch is a symptom, yeah, it isn't a diagnosis. There are a lot of diseases with pruritus, and pruritus is not a leading symptom of allergy only. Of course, you can use steroids for patients with allergies. They will work excellent. But for example, I absolutely know that you know about these diseases. For example, dermatophytosis, dermodicosis, deep pyoderma, and for example, sarcoptic mange. What do you think about these conditions? Can we treat them with steroids? But honestly speaking, these conditions are pruritic. Yeah, we can see pruritus in patient with dermatophytosis, for example, or dermaticosis. Okay, can they use here steroids? Text please me in the chat. What do you think? Okay, honestly speaking, it isn't bad sometimes use steroids. Then patient has sarcoptic mange because sarcoptic mange is really pruritic disease, but you should treat sarcoptic, yeah, sarcoptosis, of course. But if we use steroids, for example, for the cat with dermatophytosis, it's not a good decision in my opinion because it might be not so good for this cat. Dermatophytosis might be worse. So, thank you for your answers. The next one. For example, there are any conditions which can be clinically like pyoderma. For example, pemphigus foliaceus, this is an autoimmune dermatosis, or cutaneous lymphoma, or other skin tumors, for example, mastocytoma. And what about these conditions? Yes, of course, we can use steroids here, but dosage will different. Yeah, you might say that's fine. Pemphigus foliaceus and lymphoma are also treated by steroids, of course. But for allergy, we use 1 or half milligram per kilogram for dog, for example. But for pemphigus foliaceus, we can use 2 or 4 milligram per kilogram. Yeah, it's a very big difference between it. And let's look to this clinical case. It's about pruritic dogs. It's a French bulldog. You can hear, you can see it. This dog is 10 years old and 3 months with no response to anti-inflammatory doses. Yeah, 1 milligram per kilogram of steroids, oclosatinib, and antibiotics. Yeah. And before these 3 months, this French bulldog doesn't have history of skin disease. Imagine. What do you think? What do you see? What do you think about disease of this dog? Why anti-inflammatory doses of prednisolone doesn't work? What do you think? Let's look to this muzzle, to the yellow crusts and depigmentation and hyperpigmentation on the muzzle, on the eyelids. What do you think about the diagnosis of this dog? And what should we do for diagnosis? Looks like parasitic infection. Thank you very much, Karim. Just a second, I give a comment. Fungal parasites, of course. Um, Honestly speaking, if we discuss about pruritic diseases, yeah, we have 4 groups. Of course, parasites, of course, different infections, pyoderma and malassezia, dermatitis, and etc., allergies, and different tumors and neurogenius each. Skinscape and cytology, thank you very much, Karim. And the cytology under the crust, and you will see here big lymphocytes. Big lymphocytes. Yeah, and inflammatory cells, of course, and pyoderma, of course, because pyoderma is often secondary disease. Yeah, and this French bulldog with epithelotropic lymphoma, skin lymphoma. Yeah, of course, for diagnosis, we should use biopsy and therapy with poor prognosis, unfortunately. So this dog has pruritus, but anti-inflammatory doses doesn't work because they doesn't because there is a lymphoma. So what else? Deep pyoderma, of course. Not superficial pyoderma. Superficial pyoderma and steroids, there is no conflict. But deep pyoderma with fistulas, with pruritic, with then pyoderma is generalized. We should treat pyoderma firstly. However, without identifying and controlling underlying cause of pyoderma, use of steroids isn't recommended. And if you use steroids to patient with deep generalized pyoderma, it's very, very bad decision because you can have a sepsis in the end. And I have seen these patients. For pyoderma, perform cytological and bacteriological examination if it's necessary. Confirm pyoderma by cytology. It's very easy. Start rational antibiotic therapy. If we speak about deep generalized pyoderma, you should use systemic antibiotics, of course, and research for underlying cause, because pyoderma are always secondary disease. Sometimes we can use steroids without pruritus and without diagnosis. So it's very, very bad because there must be a clear indication for the use of any medication. What should we treat? We don't know. But sometimes it happens, I think, in your countries too. For example, this patient demonstrates this case. It's a bully, American bully from Crimea. And this dog has spontaneous local alopecia. You see crusts, it's specific crusts, names exfoliations. And for anchylosis, And he treated with prednisolone for 4 months and marpofloxacin for 4 milligram per kilogram 1 month without effect. Without effect, this dog doesn't have pruritus. And what do you think? Of course, we need cytology. We need scrapings. There are no parasites. There are no dermatophytosis. And what do you think with this dog? Treatment diagnosis. Yeah, treatment diagnosis is extremely bad decision. Every time I make a lot of cytology, skin scrapings, trichoscopy, and only after that I can treat. So treating a symptom is very, very bad. Of course, I will help you. This dog has leishmaniosis. I think people who live and work in South Europe, yeah, we have some know a lot of information about leishmaniosis, but for Russia, it's extremely rare disease. But we think that Crimea is endemic region for leishmaniosis. Okay. What about cats with pruritus and chronic virus infections? Oh, I have no answer for this question. But what we know about steroids in these cats. Of course, we should exclude comorbid conditions. Very, very often, this cat has dermaticosis by Demodex cati and dermatophytosis. For example, this cat on the photo has both dermaticosis and dermatophytosis, and each due to chronic virus infections. Of course, we should know the stage of disease because sometimes we can't use immunosuppressors at all. And we should aware of concurrent diseases, and we should think about life quality of this cat because if this cat has pruritus due to immunodeficiency infection, yeah, we can use steroids because the quality of life with extremely itch is very, very poor. And that case we can. And the bad news in that, we don't use any drugs. For example, we can use cyclosporine. We don't know anything about oclacitinib and cats with chronic virus infections, nothing. We don't know any articles. So antihistamines doesn't work, but we should use steroids, but exclude Demodex and dermatophytosis. Okay, we should use with caution. In patients with history of gastrointestinal bleeding, with diabetes mellitus, we can use steroid in patients with diabetes mellitus, but we should control glucose. With immunosuppressed patients, for example, oncology patients with chemistry therapy, with kidney disease, end-stage heart failure, patients with confirmed infections, extremely deep infections, and of course, pregnant patients. What else important to consider about steroids? Steroids in combination with NSAIDs carry a high risk of gastrointestinal bleeding. Don't do it, please. Steroids inhibit the conversion of T4 to T3. Therefore, we know different thyroid disorders, hyperthyreosis or hyperthyreosis, should not be evaluated while a patient is receiving steroids. Please stop medications and after that, check different thyroid disorders. Biopsy, of course, including skin biopsy, should not be performed during steroid therapy because we get very strange conclusion for this biopsy for the pathologist. Please waiting the period. If you give steroids 2 or 3 weeks, you can stop them, wait 7 to 10 days, and after it do biopsy. But if patient gets a lot of steroids, more than several months, you should stop it and wait a lot, 3-4 weeks. And of course, we shouldn't perform testing for Cushing's syndrome while the patient is on steroids because it isn't informal. What about topical steroids? I absolutely love topical steroids because they are safer than systemic steroids. And if I can use shampoo with betamethasone or clobetasol, I do it. I prefer aceponate formulations, for example, hydrocortisone aceponate. You know, Cortavans, yeah? Because these formulations have the lowest systemic absorption and they are rather potential. For example, you can use Cortavans for atopic dogs once a week and it's enough. But remember that topical steroids has adverse effects, and the more potent the steroids used, the higher the risk of adverse effect. Very rare I can see systemic effects of using potential steroids. In small dogs, if the owner use steroids like betamethasone, yeah, and the dog contacts with owner's skin and demonstrates signs of iatrogenic hyperadrenocorticism, yeah. So anamnesis is very important thing in our work. What else? We can see skin thinning in cats and small dogs, and spontaneous alopecia. For me, spontaneous alopecia is the most often side effect, but you can use steroids rarely, for example, once 2 weeks, and everything be okay. So, in conclusions, dear colleagues, glucocorticosteroids are essential medications in the work of veterinary dermatologist. Yeah, I use them every day. I think 10 times a day. But we know for some patients they are life-saving. Yeah, for example, if we have a cat with pemphigus foliaceus generalized, okay, we use prednisolone and significantly improve quality of life, of course. Then used rationality. They can instead lead to a large number of adverse effects, of course, and it's essential to apply clinical reasoning and professional judgment to every case and every prescription. Ask your questions. Ask your question for each patient. Should I use steroids or I don't? So, thank you for your attention. Dear colleagues, thank you for your comments. Do you have any questions? Because after my webinar, I'd like to invite you to take part in our DERM course. And my colleagues will tell you about them in the details. Okay. I think I should wait. Questions? Yeah, you can start. Okay. Fine, I can see your questions. Just a moment. Oh, Karim, thank you for your question. It's controversial. We should choose adverse effects or good effects of steroids. Benefits of steroids. And sometimes I check to treat the patient. Sometimes I don't. I think it's about each case. For example, I have some dogs with atopic dermatitis, and they are so chronic. You mean these close years and etc. And lichenification, hyperpigmentation, and I understand that I should use steroids. But this dog has diabetes mellitus, for example. So, and that case, I understand that if I use steroids, diabetes mellitus wasn't under control, yeah? And maybe in this case, I prefer topical steroids. Yes, it will be longer, but we won't have side effects for diabetes. And for example, the same dog with diabetes and pemphigus foliaceus, of course, I use steroids. If this autoimmune disease is generalized and the dog feels terrible, of course, I use steroids. And yes, I understand that diabetes mellitus wasn't under control. Okay, the next question. How long needs to use steroids after the signs subscribing case in autoimmune disorders? Or it depends on the case. I have some cats with pemphigus foliaceus. I treated them 2 weeks, and that's all. And I have one cat right now. I'm treating it, and I have to use dexamethasone. Yeah, prednisolone doesn't work in this case. I use dexamethasone for 3 months, and we don't have a remission. Yeah, we have 3 drugs: chlorambucil, dexamethasone, and oclacitinib. And we have poor remission, so it depends. We don't have the answer. Unfortunately, we don't have an answer. Okay, thank you for your questions. It's really nice. Okay, the question about steroids in cats. We don't know clearly about immune system, but we absolutely know that cats' steroid dosage higher. For example, if I start in atopic dog, prednisolone 0.3, 0.5 milligram per kilogram. In cat with atopic skin syndrome, I start with 1 milligram per kilogram, maybe 1.5. Yeah, the dosage are higher, absolutely. Okay. Thank you for your question. The next. Ainur, thank you very much. Yes, of course, because then we have a geriatric patient. I think this patient may have hair, heart failure, kidney diseases, and etc. Of course, before using steroids in geriatric patient, we should check their health. Yes, I check blood tests and ultrasound, abdominal ultrasound maybe, for be sure that this patient is a bit healthy. Okay, the next question. Just a moment. Thank you very much. About dermatologic conditions, do you see most commonly mismanagement with steroids? Yeah, deep pyodermas, of course, dermaticosis, of course. Sometimes dermatophytosis, leishmaniosis. Yeah, and different autoimmune disease. Honestly speaking, that's which in general practice use steroids. For example, they suspect that, it could be pemphigus foliaceus. I know. I see yellow crusts in a cat on the ears, and okay, I use 1 milligram per kilogram. It doesn't work. Yeah, if you have autoimmune disease, you should use immunosuppressive dosage of prednisolone, 2, 3, or maybe 4 sometimes milligram per kilogram. If we have dogs, I often use pulse therapy. Then you use 10 milligram per kilogram prednisolone 3 days, but after that, you should use 1 milligram per kilogram. There are an article about this type of therapy, I mean pulse therapy by Thierry Livry. Okay. Okay, thank you guys for your questions. I hope my lecture will useful and interesting. So, dear colleagues, I'd like to invite you take part in our DEM course, and my colleague will tell you details of this course by Orthopeds Academy.
So this is me again. Thank you, first of all, Dr. Lydia, for this impressive presentation and this great insight. I would like to invite you guys to join our course, and I would remind you again to join our Instagram channel to be updated about all the content that we provide. Thank you guys for your patience. I hope this webinar was interesting for you.
Yes, I think that's all.
I hope this webinar was interesting for you guys, and I wish you great evening, great night for everyone, and that's all. Thank you, Dr. Lydia, and goodbye, everyone.
Thank you. Bye-bye.